going to go on to our next section, and we're going to talk about relapsed and refractory HER2 positive metastatic breast cancer. This is an area where we've had, enormous progress over the last year, but, over the last couple of decades, of course, made huge advances. And first, we want to hear from Tiffany a bit about, what we see in patients who've progressed after the 2 lines of therapy, our classic treatments in HER2 positive breast cancer. What's the typical outcome, and what are you thinking about in those patients?
Yeah, so happy to chat about this. I think we've had so many new exciting agents, but just to set the landscape of where we've been traditionally, we have, if we're looking to phase 3 data, we've got the original capecitabine trial that we could perhaps extrapolate from, and thinking about a little bit later line, where median time to progression for just capecitabine was measured in a few months, maybe an improvement from 5 to 7 months, and overall survival in that trial was about 17 to 19 months with the addition of the HER2 targeted therapy. If we look at the Emilia study, which, as you remember, was capecitabine versus T-DM1, their median progression-free survival was still just measured in months in the 3rd-line setting, an increase from 6 to 9 months on average for median PFS, and overall survival maybe stretching out to about 2.5 years with T-DM1. So I guess that's the evidence we had in around the 3rd-line setting and later of what our expectations were for, say, time to progression or progression-free survival, really about 6 to 9 months or so. And now I think that puts into context what we'll talk about in so many of the new agents we have for HER2 positive advanced disease and how much better we can do.
And CNS metastases are a big challenge in that setting also.
Absolutely, absolutely. Where we really haven't, oftentimes these patients with progressing CNS metastases are excluded from the typical, randomized phase 3 trials that we're looking at for new novel agents in the space. So that is also an exciting, changing moment for HER2 positive advanced disease in patients with brain metastases.
So, we have, as you pointed out, seen a lot of really interesting data in the last year, and with a bunch of different agents. So, Claudine, could you tell us some about the sort of top level results from some of these trials that we really feel are going to impact our clinical practice?
Absolutely. So yes, it's been a really exciting time, and beyond 2nd-line therapy for HER2 positive breast cancer. We've had Cleopatra. Well, we first of all had trastuzumab that came on 1st line that showed us a survival advantage. Then Cleopatra with adding the pertuzumab for 1st line, and became our standard therapy there. And 2nd line became T-DM1. And really after that, as Tiffany mentioned, there were a number of options, but there was no clear winner. And we were often just cycling out different chemotherapy drugs with trastuzumab. But in the last year or so, we've seen some results of some really pivotal trials, most of them randomized phase 3 trials, but a couple of phase 2 trials that have really changed the landscape for us entirely. These drugs typically fall into classes. Most of the newer drugs that we're seeing are tyrosine kinase inhibitors of sorts, but the trastuzumab deruxtecan is a new antibody drug conjugate, and that's a study that was presented just at San Antonio this year, and really showed probably the most phenomenal waterfall plot that many of us have seen in a trial. And just to give you high level on these, just to remind you what's different about this drug, it's an ADC, just like T-DM1 is an ADC, but the payload is different. So that the payload with this drug is a topo-1 inhibitor, and there's a very high drug to antibody ratio. There's also some bystander effect with it easily crossing the cell membrane. It has a relatively short half-life, so the thought is that it can get to neighboring cells but doesn't hang around for very long. So what was seen in this study was that this was a very heavily pretreated group of patients. They had a median of about 6 prior therapies for HER2 positive disease. They had to have had prior trastuzumab, and the patients also had to have had prior T-DM1, and about 2/3 of patients had had prior pertuzumab, and the objective response rate was about 61% in the study, and it was really impressive. As I mentioned, for the patients, there were very, very few patients who progressed. Most patients had a response. but 61% had an actual objective response. And if you think about the median number of prior therapies, that was really very impressive. The side effect that was seen, that I think is the one that we need to think about most and that was the most concerning, is that a subset of patients had interstitial lung disease that developed. So any grade was about 13.5%, but there were about just over 2% of patients who had fatal ILD with this drug, which is obviously a very, very concerning side effect. And really, it seemed like if drug was continued when you had just abnormalities on X-ray, that could progress very rapidly. So that is something for us to keep in mind. This drug did get FDA approval, so it is available. Some institutions have it available already. I think one of the things that we might want to talk about is how we think about these drugs in this era that we're in with the COVID-19 pandemic, where we're really worried about pre-existing lung disease and what that might do to increase risk. But this drug is really an exciting drug. It has very quick activity in patients, and most patients had some degree of response, and the duration of response was also very long with this drug. So I think it's a really exciting drug for us to have available for our patients.